I hope that we will all engage in a critical discussion on this very important and timely public health issue that we're going to discuss today. So today we'll be discussing the paper that is titled Addressing the Re-emergence and Resurgence of Vaccine-Preventable Diseases in Africa, a Health Equity Perspective, which is authored by Dr. Adriano Lubanga and colleagues, which is published in Human Vaccine and Immunotherapeutics in 2024. So in terms of our session format today, it is also a learning platform for our junior doctors as well as for our registrars as well. But also just a discussion for us as clinicians and public health experts to really just discuss these important issues. So our format today is that we go into first have a structured summary of the paper by our junior doctors, which is Dr. Refilwe Machaka and Dr. Mpogumete, which is our medical interns that are currently rotating in the Department of Public Health Medicine, and they are second-year medical interns. And Dr. Machaka graduated from University of the Free State and currently is interested in obstetrics and gynecology, while Dr. Busimo Haule graduated from Walter Sisulu University, and her interest currently is in psychiatry. And we are honored today that we are joined by our author, one of the authors, Dr. Adriano Lubanga, who is a senior research fellow at Clinical Research Education and Management Services, which is CRIMS in Malawi. He's a dedicated medical doctor and public health researcher with extensive expertise in combating infectious diseases, which are prevalent in tropical regions. His research focuses on antimicrobial resistant, neglected tropical diseases and the effects of climate change on infectious diseases. He adopts a One Health perspective. Colleagues, may I kindly request that we mute ourselves as we join in so that we can, I don't know who Matebula R is. Could you please just mute yourself so that then we can minimize. Yeah. Okay, thank you very much. And pardon me for that. So Dr. Lubanga adopts a One Health perspective when he tackles health challenges holistically, integrating human, animal, and environmental health. He was honored with the Royal Society of Tropical Medicine and Hygiene Early Career Grant Program, the award in 2024 for his project, which was towards the typhoid-free community, which evaluates public knowledge and practices in preventing typhoid disease in high-risk urban and peri-urban areas of Malawi. He's also the principal investigator in the Malawi Early Infant Nutrition Optimization Trial project, which is called MEINO, and has co-led so many other projects in partnership with both government and non-governmental institutions in Malawi, as well as in Africa. He has contributed to policy discussions at the Ministry of Health, Malawi, and continental level through the AUDA NEPOT consultative meetings on African primary healthcare programs, and is recognized for his innovative approach and dedication, he continues to be a vital figure in addressing global health challenges. And through Google Scholar and ORCID profile, you can really just explore his work further. We are really truly honored to have him here, and we can see that we really have a robust discussion and learn even more in terms of her research interest. And then after we have the summary of the paper, and the critique by our junior doctors, we will then have Dr. Lwazimpuku, who's our registrar, who will serve as a discussant, and he will lead us into a deeper conversation of the paper's key themes, its implications, and area of further thought. And then we will then open it up for questions and comments and have an interactive discussion, which will include insights from our author, Dr. Lubanga, And finally, we'll then take a closing remark by one of our specialists here, who is based in our tertiary hospital in Tembisa. She's also a public health medicine specialist, a fellow in the College of Public Health Medicine in South Africa, who is interested in non-communicable diseases, health promotion, but with a main focus on mother and child as well, which is Dr. Mandwa Chisale Mabosha, who will deliver the closing remarks, summarizing key takeaways from our discussions and also providing reflections on the way forward. Colleagues, this is a great opportunity for us to critically engage and also apply the findings of this paper to our public health context. So I really would like for us to engage and have an insightful discussion at the end of the session. So with that said, I will now invite Dr. Machaka and Dr. Gumede to flight their presentation. I think we will first take the summary of the paper so that those that did not have time to go through the paper can then have an idea really of what this paper is. And then from there will be followed by the critical appraisal. Over to you, Dr. Machaka and Dr. Gumede.
Can everybody hear me?
Okay, we can see the presentation. Can you please start?
Everyone, I'm Dr. Machaka. I will now be presenting the summary. Good afternoon, I'm Dr. Machaka. I will be presenting the summary of the article regarding that is titled Addressing the Re-emergence and Resurgence of Vaccine-Preventable Diseases in Africa. So as you can see, that is the title of the article and the authors of the article, and it was published last year, July 2024. So the contents of the presentation will cover the introduction. We'll just summarize the overview of the vaccine-preventable diseases and the impact of the vaccination, the current epidemiology of the vaccine-preventable diseases and the re-emergence, and the factors that contribute to re-emergence and resurgence of VPDs, how they are planning to tackle the vaccine-preventable diseases in Africa, and then we are going to conclude. So in the introduction, clearly states that the discovery of effective and safe vaccines against several diseases has changed how we practice modern medicine in general. So since the establishment of World Health Organization expanded program immunization, and the Global Alliance for Vaccine and Immunization. Many important infectious childhood diseases vaccination against has enhanced dramatically. So despite the life-saving intervention being more than a century old, our continent, which is Africa, it still lacks the capacity to manufacture the vaccines that we need to save these childhood diseases. So the re-emergence of these preventable diseases amidst the rising new infectious diseases basically threatens to reverse the initial gains made in the fight against these infectious diseases. So now we're going to be talking about the vaccine-preventable diseases and its impact. So this is a list of the most common ones, the vaccine-preventable diseases, which are cholera, Ebola virus disease, hepatitis, HPV, influenza, rotavirus, yellow fever, typhoid, malaria, tetanus, measles, polio, pneumonia, rubella, meningococcal meningitis. So since the launch of our EPI in 2024, the vaccination in Africa has increased substantially, leading to major gains in infectious disease control. So this vaccination has led to a significant reduction in morbidity and mortality associated with these diseases that can be prevented by vaccination. So currently, the epidemiology of these vaccine-preventable diseases and the re-emergence. So 4 million deaths are averted every year by these vaccinations. So in 2018, 700,000 children died due to these diseases that could have been prevented by vaccination, of which low and middle income countries were disproportionately highly affected as compared to high income countries. So measles remains one of the major leading causes. Many countries have triumphed in the eradication of polio. However, countries such as Malawi have reported 5 cases of polio. This is now in 2022, 2023. So with regards to hepatitis B virus, globally in 2019, about 296 million people were living with the chronic hepatitis. So Africa had the highest number of people with chronic hepatitis, which was estimated to be 81 million people, presenting 6.1% of the population. So the most recent outbreak of diphtheria was reported in Nigeria in the early 2023, which recorded 557 cases affecting 21 of their 36 states. So overall, the vaccines have contributed to a decrease in the incidence and prevalence of the vaccine-preventable diseases and their associated mortality and morbidity. So there is a notable suboptimal surveillance for most VPDs and vaccine refusal among communities, which poses a risk for the resurgence and the persistence and undermines the effort to set and achieve realistic elimination goals for the diseases. So these mostly are the factors that contribute to the re-emergence and resurgence. So a decline in vaccine coverage, vaccine failure, pathogen evolution, weak healthcare systems, travel and migration, impact of climate change, vaccine-derived strains, and limited local vaccine production capacity. This is how the article said they're going to tackle vaccine-preventable diseases in Africa. So they're going to educate and raise awareness. They're going to boost local vaccine manufacturing capacity, strong priority setting, policy support and human capacity development, climate change mitigation, strengthening disease surveillance, fostering equity and inclusion. So in conclusion, the re-emergence of vaccine-preventable diseases undermines the significant strides that have been made in the fight against these diseases. So to address this escalating concern, it is vital to address the contributing factors, which include the health inequity and vaccine hesitancy amongst our communities. Well-functioning health systems, including strong governance, stable financing, and a dedicated healthcare workforce are critical for dealing with any emerging health threats. These are our references for the summary that we're presenting today. Thank you.
Thank you very much, Doc, for that succinct summary. So I think we will then move over to the critical appraisal. And I just want to ask Dr. Lwazi to also get ready in terms of his presentation. And colleagues, if there are any questions, you can...
Good afternoon, I'm Dr. Mhaule. I'll be presenting the critical review for our article that was just presented by my colleague now. So our contents include introduction, background, methods, results, discussion, strength and limitation, and conclusion. Critical appraisal. So our article, it follows a narrative, it's a narrative review. So what is a narrative review? It refers to an attempt to summarize the literature in a way which is not explicitly systematic, where the minimum requirement for the term systematic relates to the method of search, but in a wider sense includes a specific research question and a comprehensive summary of all studies. The title of the article is said it's addressing the re-emergence and resurgence of vaccine-preventable disease in Africa, a health equity perspective. The title is clear and it describes the study's aim clearly. The abstract, it provides a structured summary including background, objective, key findings, and recommendations. However, it does not explicitly mention the study design and also doesn't mention the participation rates or potential biases. So in our introduction, what was the rationale? So the rationale of the article, it is described in the context of existing knowledge, and the rationale of writing the article was very relevant. With the objectives there, they were clearly stated in that the aim is to address the re-emergence and resurgence of vaccine disease in Africa. Protocol and guidance. This review followed the SANRA, which is the scale for the quality assessment of narrative review article guidelines, eligibility included. So in the inclusion criteria, the relevance to vaccine-preventable disease in Africa, it reports the resurgence of disease like polio, measles, diphtheria, etc. Health equity focus, it addresses disparities in vaccine access, distribution, or policies affecting different population groups. Public health and policy studies, the research on immunization program, governmental policies, and intervention aimed at addressing BPDs. Exclusion criteria, non-English or untranslated studies. If the authors only reviewed literature in English, non-English sources might be excluded. Studies not focused on BPD's article about other public health issues unrelated to vaccine, e.g. food sanitation, nutrition, unless if it is linked to immunization. Search strategy, the author used evidence from previous studies and statistics. The sources are credible and relevant with quality evidence and clarity. The author critically engaged with existing literature. It was not opinion-based. The article highlighted particular countries in Africa where the issue is more pronounced and highlighted certain vaccines and diseases more than others, such as polio. Information sources, it does not describe all information sources and all current evidence is shown. A full search strategy is not included. Not all used terms are detailed and not all databases are used are quoted. Data charting process, there was no methods for data charting described. It rather gives an overview of resurgence from other articles. Availability of data and material. All material used for preparation for this article are available upon request from the corresponding author. Disclosure statement, no potential conflict of interest was reported by the author or authors. Author contribution, all authors contributed to the manuscript writing and proofreading and approved the final manuscript. Protocol and registration, a review protocol exists and where it can be accessed. Eligibility criteria, there is no eligibility criteria mentioned. Exclusion of studies from high-income countries and article containing protocols. The authors reported that there is no funding associated with the work featured in the article. What was our overall opinion? What was done well? The article adheres well to the SANRA checklist, with clear reporting on items, detailed methodology, clear discussion of findings and limitation, and what could have been done better, inclusion of statistical charts and diagrams. The author related their findings to existing literature and the implication of public health are clearly stated. Summary, it summarizes the main findings of existing knowledge. In limitations, the selection of sources may be subjective, leading to potential bias in the evidence presented. The article does not disclose how the sources were chosen. limited generalizability. It discusses broad concepts. Their conclusions may not be applicable to specific settings or population without further empirical validation. In conclusion, it provides an interpretation of the results, discussing implication for practice and recommendation for future research. It acknowledges limitation and suggests areas for future research, and also the recommendations are realistic. Thank you.
Thank you very much, Doug, for that critical appraisal, and thank you. I think, as I indicated in the beginning, this is also a learning platform for our junior doctors. I think that's great that you found a framework that you use there in terms of the SANRA. And I think in as much as with this particular one, how they've approached it, they didn't really score it, but I think we can see that from this article really it scores really well in terms of its structure and relevance and reasoning as well. So thank you for that. So colleagues, I just want to say that at this point, if you do have questions that you have, you can put them on the chat or jot them down. We now go into delve into the discussion by Dr. Lwazimpuku, and then after that we will have a discussion. I will open it up now that we can have discussions together with our author who is present. So please do jot down your questions. You can even put them on the chat so that then when we open it up for discussion, then we can then discuss everything that you have in mind. Thank you, Dr. Lwazimpuku. Over to you.
Thank you, Chair, and thank you to my colleagues for the good summary and also the just a good and well-structured critiquing. So I'm Dr. Lwazimpuku, the Public Health Medicine Registrar at UP, and today I'll just be taking you through the public health relevance of this article. I think it's quite a very relevant topic that we're discussing in this article, especially in terms of what's come to light in the past few weeks. So I'll just be discussing the basics around the vaccine-preventable diseases. Just give a quick history on the expanded program on immunizations, and then a global and South Africa overview of the impact of EPI, and then challenges to immunization coverage. So we look at the impact of COVID-19 slightly, and also look at what's currently topical, Trump's funding withdrawal. And then we'll look at the solutions for strengthening immunization efforts based on what has been described by the author. Vaccination is one of the most cost-effective public health interventions. So vaccine-preventable diseases accounted for millions of preventable deaths, particularly in low and middle-income countries, including South Africa. Despite the progress in all these things, VPDs are still resurging due to funding challenges and vaccine hesitancy and health system weaknesses. Now, just to go through a quick analysis of VPDs, the WHO identifies 23 VPDs, including but not limited to these ones that I've mentioned. I'll quickly talk about the bacterial, viral, and emerging. So the bacterial, we noted that there's diphtheria vaccines, Haemophilus influenza type B, meningococcal disease, pertussis, pneumonia, tetanus, tuberculosis, typhoid, and cholera. For viral, we note that there's hepatitis A, B, and HPV, which I'll discuss later on, and then influenza, measles, mumps, polio, rabies, rotavirus, rubella, yellow fever, and Ebola. And then emerging vaccines, currently in the pipelines for malaria, dengue fever, and RSV. And then just important to note that vaccine-preventable diseases are responsible for a significant proportion of child mortality worldwide, necessitating a robust vaccination program. The significance of these, as mentioned, they cause a significant amount of morbidity and mortality, especially in the under 5 age group. And then without vaccines, outbreaks can escalate and overwhelm health systems. Some vaccine-preventable diseases like measles, rubella, and diphtheria are resurging in South Africa, which I'll touch on later. So what is EPI? The expanded program on immunizations was established by the WHO in 1974 to provide equitable access to life-saving vaccines. Initially, it was aimed at childhood immunizations for a select few diseases, but now covers individuals across all age groups and now a broader array of conditions. It's recognized as one of the most cost-effective and impactful public health innovations. So just to talk about the historical milestones, initially, as mentioned, it targeted 6 childhood diseases, namely tuberculosis, diphtheria, tetanus, pertussis, polio, and measles. Then it moved on to another milestone, which was smallpox eradication in 1980, which was a major achievement. Then by the early 1990s, global childhood immunization coverage reached 80%. It also expanded to 13 universally recommended vaccines and 17 context-dependent ones. Polio cases reduced by over 99% through global efforts, and the creation of GAVI, the Vaccine Alliance, enabled broader vaccine access for our communities. And then there was also the introduction of vaccines against Haemophilus influenza B, pneumococcal infections, rotavirus, human papillomavirus, meningitis, and Japanese encephalitis and malaria. So now we just want to see what the impacts of EPI have been at a global level. So looking at the broader impact, innovations like safe injection practices and solar-powered health facilities have benefited other health programs, not just the EPI. It's played a crucial role in the rapid deployment of COVID-19 vaccines, and it's expanded target population beyond children to include adolescents and adults, which is very important. The current EPI vaccines that are noted, 13 universally recommended, but each country does its own context-specific ones. So BCG, diphtheria, pertussis, tetanus, Haemophilus B, hepatitis B, polio, measles, rubella, pneumococcal disease, rotavirus, hepatitis, human papillomavirus, and COVID-19 for adults. This was during the crux of the pandemic. Then context-dependent vaccines are yellow fever, vaccines against the different organisms that cause meningitis, Japanese encephalitis, and cholera. And then a global collaboration and future goals of the EPI. So it works alongside other public health initiatives to enhance disease control and strengthens primary health care access, particularly in marginalized communities, which you see a lot in low to middle income countries. And then the 50th anniversary highlights the past achievements and sets future goals for improved immunization coverage and equity. Now we'll look at the immunization agenda of 2030. So it's a global strategy endorsed by the World Health Assembly to strengthen immunization over the next decade. Now, short of a few years, it aims to save over 50 million lives by ensuring equitable vaccine access for all ages, and seeks to maintain immunization gains, recover from COVID-19 disruptions, and expand coverage. So there's a very strategic approach, which is a bottom-up approach, engaging countries to align with local needs. It also is designed to be flexible and adaptable based on emerging challenges. And it also includes a very important M&E framework to track progress at a global, regional, and national levels. Now, the core principles of IA 2030 are that it's people-centered, ensuring equitable vaccine access. It's country-led, governments set context-specific targets and action plans. It's partner-driven, collaboration amongst the key actors and key stakeholders. And it's data-driven, based on this M&E framework to refine strategies and improve outcomes. And also looking at still the global picture, it's important to touch on the SDGs, namely SDG 3, 1, 4, and 5, as these play a significant role in terms of the EPI program. So SDG 3 looks at good health and well-being, target 3.8 which is to achieve universal health coverage, also including vaccine access. And then target 3B, to support research and development of vaccines. SDG 1 refers to no poverty, and vaccination reduces healthcare costs, preventing families from falling into poverty in certain ways. Then SDG 4 talks about quality education, and then healthy children perform better in school. That's how the EPI addresses it. And then SDG 5, gender equality. So an HPV vaccine reduces cervical cancer risk, promoting women's health. And this is how the EPI has targeted these SDGs. In South Africa, the EPI was introduced in 1974 with 6 initial vaccines and has expanded significantly. So I'll just talk about the key developments since then. So in 1995, there was the introduction of the hepatitis B vaccine. And then in 2009, the addition of rotavirus and pneumococcal vaccines. In 2014, the introduction of HPV vaccine for adolescent girls. And 2021, the inclusion of COVID-19 vaccine, where we saw how well the systems could work together and bring about a vaccine in a very short space of time. So its goal is to achieve universal health coverage and maintain South Africa's polio-free status, amongst other things. Now, this is just another look at it, just as a timeline. As you can see, from 1974, EPI launched with 6 conditions in mind, all the way to us actually now having a combined measles and rubella and Tdap vaccine. Looking at the impact of EPI, global achievements, vaccinations have prevented 4 million deaths annually. Between 2010 and 2018, measles vaccination alone averted 23 million deaths. Human papillomavirus vaccine reduced cancer-causing HPV strains prevalence by 83% among teenage girls. And we've also seen that vaccines prevent 24 million people from falling into poverty. And then it's also very cost effective. We see that for every $1 invested in the measles immunization, as an example, there's a $76 return and economic benefits. Now, looking at South Africa's achievements, measles deaths have dropped by 84% between 2000 and 2015. And then just quickly talking about the targets for EPA coverage in South Africa. So measles first dose and second dose must be greater or equal to 95%, and under 1 immunization coverage must be greater than 90%, and dropout rates must be less than or equal to 6%. So the article highlights a few challenges that we have in terms of vaccinations and vaccine-preventable diseases. So these challenges I'll speak to are health inequities, vaccine hesitancy, weak disease surveillance, political and economic stability. So in terms of health inequities, remote and marginalized communities have poor vaccine access, and then 0-dose children, those who've never received vaccine. And then in 2023 and 2024, we noted that South African children, 21% of South African children missed their first measles dose. When it comes to vaccine hesitancy, fear, misinformation, and distrust lead to vaccine refusal. And then social media amplifies anti-vaccine misinformation, which we've seen through multiple social media platforms, such as X, Facebook, and Instagram. And then weak disease surveillance. Measles cases indicate weak immunization programs. Poor data collection affects vaccine supply chain making decisions. And then political and economic instability. Conflict zones disrupt immunization programs. We see this in DRC. And then in terms of climate change, it increases the burden of disease. So cholera outbreaks due to flooding. And this is just a piece that I've taken out from the article. Just quickly going through the, as a schematic diagram, just quickly going through the challenges that we face in terms of vaccine-preventable diseases. So we see that there's a decline in vaccination coverage, vaccination failure, pathogen evaluation, weak healthcare systems, as noted previously, travel and migration, since we now live in a global community, and then impact of climate change, vaccine-derived strains, which are now becoming more prevalent, and then limited local vaccine production capacity, which is very important in our context in Africa. Now, I just want to give you a snapshot of what we're currently seeing in South Africa over the past few years. So this is just taken out of the Department of Health, South Africa's EPI. So we see that there's actually targets that we have set. We have the measles first dose coverage, and then we also have what you call this vaccine dropout rates, as discussed before. Then if we see that they've listed a number of targeted children, and we see the actual coverage that we've noted, for example, with measles coverage first dose is 82.5%. And then we see that with measles coverage second dose, it's 84.8%, right? So now we look at the last column of the table, we see the proportion of children missed. We see that with measles coverage first dose, it's 21%. With measles coverage second dose, it's 18%, which is very important for us to bear in mind, because now this would have an impact on herd immunity. And then just looking at the WHO African region, looking at diphtheria vaccine, we see the first dose and second dose and third dose have been mapped out. We see that over the past few years, from 2000, there's been a steady increase in terms of vaccination coverage, in terms of both these doses. And we see that there's a drop starting from 2000 all the way to 2015 in terms of the number of cases. Now, more particular interest, we see that at around 2019, and just after 2019, there starts becoming a dip in the vaccination coverage. And we note that there's still a decrease in the number of cases of diphtheria, but now in 2023, 2024, we've seen a resurgence in the number of the diphtheria cases. When looking at South Africa specifically, again, we see a similar trend where there's a decrease in the number of cases of diphtheria as the vaccination coverage increases. But of particular note, again, we see that cases begin to rise again at the 2020 mark, where there's a slight dip in vaccination coverage. And then now we'll just discuss the current outbreaks. So current outbreaks happening in South Africa from 2024 to 2025. There's a measles outbreak between week 1 and week 46 of 2024. 626 laboratory confirmed measles cases were reported in South Africa. Gauteng reported the highest number of measles cases, that is 285 cases. And from week 41 to week 46, 104 new cases were confirmed, 64 of them being here, Gauteng. So measles surveillance challenges were noted. So there were misallocation of cases from other provinces to Gauteng due to missing patient data. There's high rates of false positive measles IgM cases co-infected with rubella. And there's delayed laboratory results affecting timely outbreak response. As we know, last year we had a data breach in terms of our national laboratory health services. Then looking at the diphtheria outbreak 2024 to 2025 data, 40 cases of toxigenic C. diphtheriae were detected between January 2024 and January 2025. 20 of these cases were respiratory diphtheria with a 25% fatality case rate, 5 deaths. Majority of these cases were reported in the Western Cape, 37 out of the 40 cases. Cape Town Correctional Facility was noted to have 12 asymptomatic carriers identified. And then in January 2025, 1 respiratory diphtheria case was reported in Gauteng. And this could be found on the alerts page on the NICD website. Now, to come to the elephant in the room, the current problems that we are facing. The US is a major source of funding for health research in South Africa. Many of the country's institutions, groups, and universities receive funding from US through National Institute of Health, the CDC, USAID, and PEPFAR. So now we'll look at the specific impact of President Trump's decision to stop aid to Africa. We'll see that there's disruption of immunization services. The cessation of funding has led to closure of several health programs, causing patients to flock to strained public health facilities. In KwaZulu-Natal, with the highest HIV prevalence in the country, it sees HIV rates increasing weekly. This does not only have an impact on HIV programs, but also the EPI as well. As we know, these patients are most likely to be at risk of contracting serious illnesses. And then if you look at the increased risk of disease outbreaks, we see that funding has led to widespread program closures across universities, colleges, and infectious disease institutes, affecting research and control efforts for diseases such as HIV, AIDS, tuberculosis, and malaria. We see that it also has an impact on research and surveillance. The NICD specifically relies on the international funding for its research and surveillance activities. The suspension of USAID has disrupted ongoing studies and hindered the Institute's ability to monitor and respond to communicable diseases as effectively as before. It also has operational constraints. The funding cuts have led to resource shortages, affecting capacity to conduct essential laboratory testing and data analyses. So these are, apologies, colleagues, these are the potential things that we might see happening due to the fact that funding has been cut. So what can we do about everything that's currently been discussed? I'll touch on a few points that have been mentioned by our author and my colleagues as they were summarizing the article. So we see that educational and awareness campaigns are key. Strengthening public health communication to address vaccine hesitancy, conducting community engagement programs to promote vaccine confidence, and just acknowledging World Immunization Week, which is usually held on the last week of April. Boosting local vaccine manufacturing capacity is important. It's investing in research and development for local vaccine production, enhancing regulatory frameworks to support efficient vaccine production and quality control, as discussed in the article. And then strengthening disease surveillance systems through implementing high-quality surveillance mechanisms to detect and respond to VPD outbreaks. In South Africa, we have our NICD having the event-based surveillance team, and then enhancing data collection and monitoring for early warning systems. And then also through fostering health equity inclusion will improve the situation by addressing socioeconomic barriers that limit vaccine access, particularly in vulnerable groups. This is where we draw on the social determinants of health, and then ensuring equitable distribution of vaccines, prioritizing underserved areas. We also need strong priority setting and policy support, which is done through political will. Developing evidence-based national immunization policies to guide vaccine deployment, and which are updated regularly, and allocating adequate resources for immunization programs through government and donor funding. Then human capacity development and training a workforce, by establishing specialized education programs or systems in vaccine production and immunization practices, and conducting continuous professional development for healthcare workers, thereby capacitating the workforce. And then we also have to look at climate change mitigation and VPD preparedness. So this is done through recognizing the impact of climate change on disease transmission patterns, especially when it comes to waterborne and vector-borne conditions, and then developing adaptive vaccine strategies to respond to environmental changes, which is addressed also through the IA 2030. And then colleagues, from my side, that will be the end. This is just the schema from the article that shows how we can address the challenges that we're seeing with immunizations. Thank you.
Thank you, Dr. Mbuku, for that presentation. And once again, thank you to our medical interns as well for the summary of the paper. Colleagues, I will now going to open up our discussion session. And it is really my pleasure to introduce again our author, Dr. Lubanga, and colleagues. I've seen that he is not alone. I've noted one of the authors as well being present in here. And we saw from the summary of the paper, and for those that have read this paper, that really it contributes significantly to disease prevention, specifically our VPDs that we are seeing that really they are re-emerging, and also the challenges that we are facing, issues of health equity, and also looking at our immunization programs and the challenges that we have within our healthcare system as well. And it delves deeper into the challenges and the barriers that is faced. And I looked, when I read it, like looking at the detailed analysis of those key factors that they mention, such as vaccine hesitancy, supply chain issues, the health system inequities that we are seeing. So just to start our discussion, and I'm going to ask Dr. Lubanga to come in here, or colleague, the co-author that's with him. I'd just like to start it off maybe by asking you, Dr. Lubanga and the colleagues, what inspired you and your team in terms of writing this papers? Like, what was that primary motivation for really writing this narrative? And also maybe to delve deeper into what the challenges that maybe you faced in writing this review when you were gathering and analyzing data specifically on vaccine access and hesitancy across Africa. I mean, given the fact that we know that, as you indicated even in the paper, our disease surveillance system is not that good, reporting is not that good. So I'm really interested, I think, to even know in terms of the challenges and how you navigated them in terms of gathering data that really speaks to hesitancy specifically, and maybe vaccine access. So with just those two questions, and colleague, at this point, you can ask your question, you can raise your hand or type in the chat as well. I just want to welcome now Dr. Lubanga to just give us his insight into and where things are since this paper was written, and also maybe just your insight in terms of the geopolitics, where it's going to take us, given the fact that we've actually just been on a back foot already. So what this will then mean in terms of the findings of your paper. Thank you.
Thank you so much. It's really a great honor to be here this afternoon. I'm joined by my colleague, Dr. Akim Bwanali, as well as Dr. Thomas Nyirenda, who is also the current Director of Clinical Research, Education and Management Services, CRIMS Malawi, and he also works for European Developing Countries Clinical Trials Partnership, EDCTP, and he's based in South Africa, head office. Dr. Bwanali is also a research fellow at CRIMS with significant interest in vaccine-preventable diseases. Once again, it's our greatest pleasure to be in this platform that we can talk about this paper, which we co-authored last year. We never knew that one day it will be a subject of discussion, or it will spark a bigger debate in Africa. Yeah, so what inspired this journey? I think I and my colleague, Dr. Akim Bwanali, who is also here, had a series of talks last year with regard to what is happening in Africa and the world at large, and what are the global priorities with regard to Haiti. You see that among the top global challenges that the world is facing at the moment are issues of vaccine hesitancy, issues of antimicrobial resistance, issues of climate change. And then we looked into our continent, Africa, to say what's happened. We had a surge in cholera cases last year here in Malawi. We had a relapse of polio, which was eradicated some time back. And then we also looked into Africa and saw that there were cases of measles being reported, cases of hepatitis B. So looking at that concentration and say, we have vaccines, they are working. Vaccines work, and their effect has been proven a million times. But what's the problem? So then we started digging deep into the issue, and then we discovered that there are a couple of factors or a multifactorial kind of factors that drive that resurgence of vaccine-preventable diseases amidst the ongoing challenges that Africa is dealing with. Now we talk of a dual burden of diseases, talk of non-communicable diseases, talking of communicable disease, talking of the coming of the pandemics and multiple epidemics happening at the same time. So all these had impact on vaccine-preventable diseases. But as you may also agree with me, that the African CDC and other stakeholders in Africa, they are at their top-notch or at their topmost part of the top is issues of disease surveillance, as well as preventing these vaccine-preventable diseases, and also having a strategy that focuses on boosting the Africa local vaccine manufacturing capacity with regard to that's happening in Rwanda. So the inspiration was pretty much what's happening in Africa and the need for us to do something. This was not the very first paper that we authored. There is another paper that we authored on vaccine hesitancy, which is also available, but it was particularly to Malawi and how that fueled vaccine-preventable diseases. And then looking into the interplay of climate change as well. With regard to the challenges that we faced along the way, the initial design of this paper was that it was supposed to be a systematic review, probably with a meta-analysis. But we found that with regard to access of the data, the papers and everything, much of the data was not published. We found some publications, but most of it was also in the news and in all these areas. That's why we ended up at the designing something like a perspective that you saw, but also at the end of the day that was comprehensive. So as you rightly held in the critical review, that some part of the methodology sections were missing, including putting in charts and how the papers were selected, because at the end of the day we wanted to provide an overview of what was happening in Africa. It was really a journey that took us a couple of months, but at the end of the day, we ended up coming up with this beautiful paper that we are talking about today. And I think it really summarizes very well with regard to what is happening in Africa. And you saw that this was a year ago, but what is happening now with regard to the disruption of funding, the Trump administration, the policies that are currently popping up, resonate very well with our thinking, with our thought process that probably it was time for Africa to invest in its healthcare system. Yeah, and at the same time, we need to find better ways in terms of domestic financing for disease surveillance, for research, and everything that is happening. But at the present time, let me stop there, but I can invite my colleagues, Dr. Thomas Nyirenda, who is here, as well as Dr. Akim Bwanali, to give a comment on the same, and then we hand over to you. So either Dr. Nyirenda or Dr. Bwanali.
No, thanks very much, Adriano, and thanks for getting me involved in this. I have nothing to claim from this paper. I just joined because we work very closely with yourself and Dr. Bwanali in Malawi. But just to concur on you, I think this is a foundation for good thoughts on how we can look at our continent, and colleagues have provided very important critique that if we want to move this work forward, needs to be taken into consideration so that whatever comes out provides quality evidence for addressing most of the issues that Adriano, you have also mentioned, which are basically challenges for all of us. The challenge I see outside South Africa in these EPI programs is that sometimes to also get this information in a quality way is difficult because of the way programs are run. Everything is still paper-based. There's no digital records of kids that have been immunized. As such, we miss a lot of kids that the immunization programs call zero-dose kids that still are around in our villages, walking around with having not been immunized at all, that we need to be concentrating on. And that feeds into all the aspects you have talked about hesitancy. And some of that, the part of the hesitancy is not really behavior in terms of having an attitude against the vaccine at all. It's just that the systems are not conducive to get all our kids vaccinated. Having said that, most of us have survived because of vaccines, and we must give very big thanks and a pat on the back on our mothers, most of whom are illiterate, but they make sure they take us to the clinic and that card looks nice, and then we finish and then we survive. But there are a lot, as colleagues have presented, a lot of kids that have escaped that and still pose a risk to many, many other kids. So what do? We need to invest in our own systems. There's a lot of challenges, disruptions. As you said, climate change doesn't just affect diseases of like cholera and others. You know, in many of our countries, I mean, in Malawi, there were floods just a few years back, and they destroyed everything. You couldn't go to villages to immunize the kids where you went last week because the bridges were washed out. And all those kind of issues that we think are indirect impacts on these kind of programs that will matter when funding continues to dwindle. So those are my few remarks I wanted to add. Thanks very much for all the critique and the talk that colleagues have given. And congratulations again, Dr. Bwanali and Dr. Lubanga, for your publication. Over.
Thank you very much, Dr. Nyirenda, for that input. I don't know if Dr. Akim would want to add anything. As he prepares himself, there's a question on the chat by Dr. Mabosha, who's asking if Dr. Lubanga can just give us an update as to whether there's been any of the recommendations that they've made that maybe are implemented or being considered, if at all, in Malawi in particular, and if at all, where is the progress taken from there? And that's the only question that I see in the chat. And I just wanted to ask a follow-up question, especially because Dr. Lubanga, you indicated that there's another study that you did on vaccine hesitancy. And I've just been thinking about it, and maybe not only to you, and I'm opening up to all participants to say, like what would be the most effective advocacy strategies that we actually present? And also maybe the other one that just came into my mind when I was listening to you, Dr. Nyirenda, is that, are there any other innovative delivery models that we can use that can improve immunization coverage, especially in areas where they're hard to reach, if either there's conflict or is either there's flooding or anything? Do we think that we can come up with other innovative delivery models that we can do? So I'm just going to open it up for discussion, both to the authors, but also to the participants. Thank you.
No, thank you so much. I think I can get started, then probably Akim and Dr. Nyirenda can chip in. So let me start with the recommendations that we made in Malawi. So as CRIMS in Malawi, we work closely with the Public Health Institute of Malawi, which is the main coordinator of these programs, vaccines and everything, as well as the expanded program of immunization, which is a core department, a standalone department within the ministry. So generally, once we generate findings like this, the other stuff that we did was on HPV vaccine in terms of the caregivers acceptance, and then we just wrote another paper on the factors that were driving vaccine hesitancy, especially in the fact that during the COVID-19 pandemic, we saw a huge drop in terms of the routine vaccination programs from around 75% going to around 60s in some vaccines, which was a very huge challenge. But I think over time, other strategies that the government has used was to deploy the mass immunization campaigns. So they did for when they were introducing the typhoid conjugate vaccine, they did typhoid conjugate vaccine. Then they did a polio, as well as we had the resurgence of polio as well. So they did the typhoid conjugate vaccine, polio, measles, and rubella vaccines all at once, embarking on mass immunization of children, which pretty much did very well. After 2022, we haven't reported any case of cholera. And there is another light up that we did on that, on how the campaign was successful, which is also accessible online. And then in some part of Malawi, with regard to innovative strategies that they are adopting to deploy vaccines, we talked in the paper, we talked of issues of climate change, which disrupt routine immunization programs, where Malawi was one of the very big victims. Mozambique was also the same last year. There were a lot of floods in the southern region. Health centers were destroyed. But in some areas of Malawi, they are piloting what we call vaccine delivery drone delivery of vaccines, which is quite good. It's just at a pilot phase. I've seen reports on that, but we don't know how it's going to be upscaled and everything. So that's up to the government. But once we make these recommendations, usually we drop them to the ministry, have a discussion in the technical working groups within the ministry. Usually adoption of policies is not there and then, but we hope that in the long run, whatever we talk about is going to have an impact in one way or the other. Let me leave it there so that Akim and Dr. Nyirenda can add one or two things as well. Yeah.
Thank you, Doc. Dr. Akim, do you have anything to add on? And I saw a chat by Dr. Nyirenda, who needs to drop off for another call. But he does indicate that issues of finding other innovative ways of developing vaccine is a very important one, and indicated as well that Dr. Lubanga was recently writing an application for Gavi to do that in Malawi. So that would be interesting to see. And also the issues of drone, and I think it's one of the things that I was also thinking of, to say, even technology, what it is that we can use. There's also a question by participant with number 7604. Pardon me for using that, is what I see on my side. And is that, what is the current coverage for measles 1 and 2 in Malawi, and immunization under 1 coverage? Are you meeting the 95% coverage in terms of the measles 1 and 2 in immunization under 1 coverage?
So for measles 1 and 2, we haven't surpassed the 95% coverage. But for 1, we do. I think last time I checked, it was around 92% or above 90%. For 2 was around 80-something%. But for measles 3, we are doing very poor, because we're around 75%. So I think it's just the way maybe the vaccines schedule is structured in Malawi, that you get at 6 weeks and then at 10 weeks, and then the measles is supposed to be, the last one is supposed to be given at 15 months. So usually most babies do not show up at that particular point in time. While at 6 weeks and 10 weeks, they usually get a couple of vaccines together. So we haven't reached, or we haven't surpassed the current 95 targets. Let me, if I can get something to show you from the latest Malawi Demographic and Health Survey. Yeah, but we were close to 90% for 1 and 2, but we haven't surpassed the 95% coverage. Yeah.
Thank you. Very interesting. Thank you. I think it's one of the things that we're also struggling with in terms of our coverages as well. And I think we've seen even from the presentation that Dr. Mpuku has done to say, really, these challenges as this review paper indicate that it's a continental or regional problem that we are all faced with, but we need to find ways of how we address that. Colleagues, are there any other questions or anything, or maybe if I may ask Dr. Akim Bwanali if there's anything that he wants to add so that I don't close him out.
Thank you so much. We really appreciate the opportunity to share our thoughts, our publication. So as researchers, we realize the role that we have in influencing the adoption of effective, high quality, as well as impactful interventions. So it's really an honor that we could come here and talk about our paper. Issues of vaccine coverage and hesitancy, they really do have a massive toll on the healthcare system in Malawi. We have produced a number of papers, as Dr. Adriano has already highlighted, and we really hope that the recommendations that we'll put across will be put in place by the ministry. We continue engaging with them, and it's quite it's quite glad to see when they adopt the recommendations that we make. Thank you.
Thank you very much, Doc. Thank you for that input. There's another question by one of the participants that says, now that USA has pulled funds, how will we ensure that there's vaccine coverage across the continent? And I think maybe speaking to those countries that we know that they are really reliant on donor funding as well as it is, but also thinking of the WHO support that now is being pulled for. We know that USA really contributes most, maybe, and that's one of the things that we can, that the participant is asking with regards how we're going to make sure. And I think it speaks to also some of your recommendations that you've made, but let me open it up for discussion. And yeah, and Dr. Mabusha is asking, I have an immense interest in health system factors and wondering if there has been ways of mitigating staff shortages, lack of cold chain, and no vaccine availabilities, etc. Okay, so those are the two questions that are on the floor.
Thank you so much for the questions. I think quite interesting to see these things. So if you go in the paper, deep inside the paper, you'll find that we're talking about expanding on domestic financing, leveraging on revenues, and then probably also increasing tax on some of the products. Like in Malawi, they one of the tobacco, huge tobacco producers, and then also when we are thinking about public health, we think about the whole perspective and thinking of areas where we can leverage some revenue to build on some areas that have demonstrated what impact. one of which, like Malawi are dealing with, we want to have a cut on tobacco, and also we want to have a cut on alcohol because of the impact, their impact on what? Non-communicable diseases. So such part of the discussions that are popping out in those is how can we work on maybe increasing some taxation in these areas, but some of the dividends that we get in those areas can be invested in issues of what? Of vaccines, which have demonstrable what? Impact. And then, so at the end of the day, what we need to, because we want to be supported forever, that's what the world is telling us at the present time, to say, look, everyone, like Malawi was one of among the 10 countries that were donor funded. Probably much of our budget was coming from what? The donors. But if they're pulling out, then we need to think of what? Innovative ways on how we can get to do that. So the biggest challenge that we experience also is the delivery of free healthcare in most settings, which is really, I mean, at the end of the day, there's no healthcare that is free. A model that you can deliver effective and efficient healthcare at absolutely free without insurance coverage and anything. But there can be models where we focus on building our domestic revenue and invest part of that into what? Into the success programs like vaccines. So I think that's one of the areas that people are advocating for now. The Abuja Declaration recommends that at least in every budget, the government should be allocating more than 15%. But if you look across Africa, you find that much of countries don't reach that 15% threshold. Malawi is one of them where it's around 10% or lower than that, which means a huge part of it is supported by what? Donors. But probably the Trump administration is a wake up to us to see how we can innovate on that and expand on our domestic revenue. But that's a government thing that we may not tackle. There's another question relating to issues of cold chain system factors and everything. So the biggest challenge with regard to the vaccine is to maintain the effectiveness and the efficacy of the cold chain system. So the vaccines can be there, but in hard to reach areas, if these cold chain equipment systems are not maintained, then now it becomes a big challenge in those areas that you see some cases of like polio being reported just because the vaccines that were delivered in that area were not effective. The cold chain system was not working. So what is happening at the present time in Malawi is that there is currently a project that is handled by Next Leap, where we are also engaged as CRIMS to help them in generating better ways of financing the maintenance of these cold chain systems, so that the cold chain systems are maintained at a better level. At the same time, we find whether facility-based financing systems or equipment-targeted financing system would be better. So that's something that we are being engaged on now to help them to find the best way of maintaining this cold chain system, so that the vaccines that we deliver in these hard-to-reach areas are effective. And yeah. So, but also that's with regard to sustainability of that, I'm not sure, because at the present time it's funded by Gavi through Next Leap. Here in Malawi, as CRIMS, we are just engaged. We have given them our input. We hope that maybe one or two things we can get to work together and improve on the same. But it's really a big problem in Africa when we talk about cold chains as well as vaccines availability. And perhaps now that people are establishing the African Biotech, the African Medicine Agency, in Rwanda now you see that there's a plant where people are focusing that they should start manufacturing the vaccines. So you can check that up, and that's a big win on our end. If that can proceed, then we say 20% of diseases are in Africa, but only 1% of vaccines are manufactured in Africa. That's a very huge challenge. So let's see how the future unfolds, but Probably what is happening in Rwanda should be happening in South Africa, should be happening in Nigeria, should be happening in Malawi, should be happening everywhere. Then all these things are going to be what? Tackled at the end of the day. Let me stop there.
Dr. Lubanga, thank you so much. And also Dr. Bwanali and Dr. Nyirenda in his absence for really a robust discussion. I know the paper was focusing on Africa, but it was also great for us to have the Malawi, to understand the context in Malawi and the environment of how things are going there. And we can see that really these challenges that you mentioned in the paper are not unique to just one country, but it is really a regional problem that we need to find ways of how to address them and innovate more. And you are right, I think for all African countries, this Trump administration and their executive orders is a wake-up call, and we really need to look at how we address not only issues of these health system, but we know that climate change as well is a huge thing that we also need to look at how do we then address those so that we can alleviate the challenges. Colleagues, thank you so much. I don't see any other questions on the chat. And so at this moment, I want to give it to Dr. Mandla Chisale Mabotja to do the closing remarks for us as we bring our session to an end. Dr. Mabotja?
Thank you so much, Dr. Pasha, and thank you so much to all the attendees for such a very interesting topic that we discussed in today's Journal Club. And a big thank you to all our presenters, the medical interns, the registrars for critically appraising the paper, and big thank you, of course, to our authors, Dr. Lubanga and your co-authors, for actually being present as we have this discussion and discussing your paper. Very interesting topic indeed, the re-emerging of the vaccine-preventable diseases, particularly in Africa. As we know that we have our own unique challenges as Africa. We look at the global north and the global south, we've got different challenges, and it's best to look at our challenges and come up with solutions that are best fit for our problems. So coming with solutions that are appropriate for Africa, for our own African challenges. And thank you so much to all the people who have commented, who were part of the discussion, very robust discussion we've had, and Dr. Pasha for just steershipping this boat and ensuring that we have a good, a fruitful and a productive journal club. Thank you so much to everyone who attended, and until we meet again in our next journal club, which is next Tuesday, same time, and we'll be having a very good discussion again with another paper. Thank you so much, colleagues, and goodbye. Enjoy the rest of your afternoon. Bye.
Thank you. Bye, everybody.
Thank you. Bye.
Thank you very much.
Thank you.